All right, so today we're going to be talking to Dr. Marc Bloomenstein, and in addition to being a snappy dresser, he's also an optometrist. Specifically, he works in a laser surgery center, and we're going to talk to him about optometry as it relates to laser surgery, as well as pre-surgical regimens that people can implement to ensure optimal outcomes. Dr. Bloomenstein?
I want to talk to you.
Not now, later.
No, now.
Good morning. Today we're going to be talking with Dr. Marc Bloomenstein of Schwartz Laser Eye Center in Scottsdale, Arizona. Good morning, Dr. Bloomenstein.
Good morning. It is morning here, definitely.
Very good. Well, Dr. Bloomenstein, I know who you are, and I know a lot of people know who you are, but for the people on our channel who don't, could you take a minute to describe yourself and your experience?
Wow. That's a loaded question. Who am I? I think if you ask my wife, she'll say that I'm a multifactorial, complex, sensitive yet harsh individual. But I think in general, what I kind of feel myself to be is somebody who cares about my patient's vision. I'm an optometrist who practices in a state where, you know, we have young patients and we have a very large geriatric patients population, if you will. So I guess I would break it down. One way of looking at it is that I'm somebody who feels when I walk into an exam lane, this is my opportunity to do something to help my patients maintain good quality of vision. I don't know if that's the answer you're looking for. Some people will describe me as sardonic and very caustic, but I kind of think of myself as a lover too. So,
Very good. No, that's exactly the answer I'm looking for, actually. Well, so as we mentioned at the top here, so you work for the Schwartz Laser Center in Scottsdale, Arizona. So what's it like working at a laser center like that versus, say, general optometry? What are the differences between those two?
that's a great question. And you know, when I first started practicing, so I joined a very large ophthalmic group here in Arizona, to the tune of 4 surgeons that did upwards of about 800 cataract surgeries a month. We were doing 500, give or take, refractive surgical procedures, and at the time it was a combination of RK and LASIK and some of the newest technologies. And what the optometric role in that practice was to basically do everything but surgery. And it was a really unique way for me to be able to practice to the level of what every optometrist is taught. You know, when you come out of optometry school, you're besides being a spinner and a grinner, you know, looking at, you know, better 1, better 2, there's no 3, it's better 1, better 2. You basically also have to be a primary care doctor. I mean, you literally have to evaluate from the front of the eye to the back of the eye. You need to prepare patients if there is some impending systemic condition that can change the quality of your vision, all while still providing a service like glasses or contacts or vision therapy or low vision. When I came out of school working in this secondary ophthalmic care, meaning a cataract and refractive surgery center, the role was a little different. We didn't have the retail aspect of it. I wasn't really involved with contacts, and I wasn't really involved as much with selling glasses or fitting glasses. So the role really was to evaluate the health of the eye, to put a patient in a position if they are having surgery to ensure that they're going to get the best quality of vision. So 25, 26 years ago, this was something really new and really unheard of. Nowadays, I think it's spilled in a little bit more into a primary optometric practice versus a secondary practice, but I still feel my role is that gatekeeper, the everything but treating and diagnosing patients prior to and after surgical intervention. So to answer your question in a nutshell, the line has blurred a lot because I think our profession has moved into a direction of really being medically minded. But from an acumen standpoint, it's being more prepared for the eventual potential complications of surgery, but also circumventing them prior to the procedure.
So walk me through that a little bit. If I'm a patient that's coming in pre-surgery, what is it that you're looking for, and then what would you do if you found something?
So from a refractive standpoint, it's quite simple. I feel that, you know, those of us who basically see these patients every day, we know that we're looking at the thickness of the cornea. We know that we're looking at the curvature of the eye, make sure there's no irregularity, make sure there's no like signs of disease like keratoconus or something that would prevent this person from having an optimal outcome. Moreover, looking at, excuse me, the magnitude of their prescription, seeing if the procedure that we're considering, whether it be LASIK or epi-LASIK or an implantable Collamer lens, would benefit this patient. Cataract surgery is very similar as well. Cataract today, I mean, if you think about having a cataract removed, and I think it's important for us to all understand a cataract is nothing more than an aging lens. It's no different than wrinkles or gray hair. It's inevitable. And when we think about cataracts, it's not a matter of, oh no, you got cataracts. It's, well, now you have cataracts. It's like being pregnant. You either have it or you don't. At what stage is it at? And the ability to go in and explant that lens and replace it with an implant now gives us the ability to maybe have vision, seamless vision, you know, distance, intermediate, close vision, and restore that quality back to what it was when you were younger. Now, in order for us to be able to do that, we have to ensure that the optical quality is going to be at the level it should be. So one of the things that I think kind of lingers in and around this profession and what you had just asked me about, what do we really look for? It's looking to see that we've checked all the boxes. Have we evaluated the quality of our patient's tear film? Are we looking at the ocular surface? You know, is the retina going to be able to maintain good quality of vision so that if we project multiple images on it, that the retina can sustain that? And if I could take a couple seconds, I'd tell you the most important thing right now is the ocular surface. You know, when we think about quality of tears, this complex nature of an artificial tear, or excuse me, a natural tear, is not supplemented by an artificial tear. Those are a palliative, they're quick, you know, gives us a little, it's like a mint, right? And I say this all the time, I tell this to my patients. When you put an artificial tear in your eye, it's tantamount to like a Mento or a Tic Tac. You know what? It feels good for a few minutes, get that Altoid, you know, I can just keep going naming different mints, but you put them in your mouth and after a while you're like, oh, I need another mint. So we're not doing something to sustain or change the nature of that halitosis, if you will. So we think of the ocular surface, we need to be aggressive about starting and treating that ocular surface because those tears change the quality, whether it be inflammation or whether it be irregularities to the surgical procedures. So you asked me what feels like maybe 10 minutes ago, what is it that I'm looking for? I'm looking at all of it, but one of the things that I'm hoping for is that these patients have been diligent about treating their ocular surface. You know, we hear a lot now about meibomian gland dysfunction. And to me, it's not a buzzword, it's a reality. We are all in front of monitors and computers, and I don't care if you're 20, right, swag, or if you're 80, still swag, you're on a monitor, you're on a computer, you're on a tablet, and we just don't blink as much. So we're inducing changes to the ocular surface that need to be evaluated, and truthfully, they need to be maintained or treated early. So what I'm looking for is to see where they are at this moment, and if I need to, can I do something to kind of, you know, expedite that process and prepare them for surgery?
And as far as that process that you're talking about, typically how long does that take? So generally speaking, if I come in and I'm, you know, prior to a cataract surgery or prior to a LASIK procedure or some other sort of refraction, then how long does that process take? So I come in and let's say that there's a problem that I have or an issue that I have. How long would it be before I would be into surgery and actually get things under control? Or are we even waiting for it to be completely under control? Or are we just trying to get it to a level where we can do the surgery?
That's a great question. You know, getting back to homeostasis is probably just, it's a pipe dream. I don't think that we have the ability to do that unless we started, truthfully, I think, you know, in our teens, and we just carry this on and on. So for me, when a patient's sitting in my chair, if I'm looking at a topography, you know, a curvature of the front of their eye, if it's irregular, then it may take weeks. Sometimes can take months before I start to see where it stabilizes or normalizes. For other patients, I could start them on an anti-inflammatory drop, which in turn, or even just starting some lubrication, or doing something like a thermal pulsation, you know, where we can put something on their meibomian glands to heat it up in office, get them using some lid scrubs or doing something more aggressive. I could maybe see a change within the first month or so. So it really, and honestly, it just depends on the severity of the condition at that moment. But on typical average, I would probably say about a month, if not longer.
Oh, and that's certainly not too long of a time to wait. And I think one of the things that we've spoken about with some other doctors on this channel is that it's not, you know, you're worried about, one of the things I know you're worried about is infections setting in after the surgery, but it's more than just that. I mean, there are other things on the eye that can affect even your vision after the surgery, where you had this surgery expecting to come out with great vision, but if your eye wasn't in the right place, then maybe you come out and you don't get as good a results as you would have expected.
Right, and totally. I mean, for me, honestly, infection is not as important, and I'll tell you why, because we have some great antibiotics. And if you go back and look, especially with LASIK surgery, the reality is that the chance of developing a postoperative infection is extremely rare. I mean, extremely rare. With cataract surgery, it's even, you know, it's a little bit higher, but it's so rare as well. And a large part of the reason why is because most of the bacteria or some of the problems we'll see are from the patient's own genome. So it's bugs that are basically existing in and around their lid margin. And so you asked me, excuse me, about treating preoperatively. One of the things that we started doing is we started using like a hypochlorous acid to clean around the lid margin prior to surgery for about 2 weeks. And I think it's a fantastic opportunity to kind of change the flora. So we don't see as much of a bacterial load in and around the eye during the surgery. But that also kind of contributes to the thing that I think is more important, which is twofold. One is expectations. I think that, and I keep saying this, so if anybody, I stole this from somebody, I don't know who it is, but, you know, perfect is the enemy of good. And I think that, you know, if we create this sense of, oh, it's going to be perfect, no, you know what, we're going to get you really good vision. So one of the things that we need to do to accomplish that, though, is we need to sustain a good ocular surface. And I keep coming back to this because I think it's really important to me postoperatively for patients to have good quality of vision. If they're not getting good quality of tears, if the surface isn't good, then that to me is a bigger challenge than dealing with infection or dealing with even with postoperative inflammation. So it's interesting how, you know, we've kind of changed a little bit of this. It's been a sea change a little bit.